Okay, so you've been introduced to Youssef and Tima. So let's carry on and look at a case study with one of them. The case study involves Tima, who has been presented to a district hospital. I'm the general surgeon at the district hospital, and she is unconscious as a result of a violent altercation. The only bit of data we have on her in initial presentation is her temperature. I come in and I do as I would do to any patient, is speak to them. I look at her chart and say, Tima, Tima. She doesn't respond. I see some bruising on her face and it makes me concerned that she has a head injury. I tell the nurse to put on a cervical collar. I want to check her airway. It seems to be clear. And I am concerned that her level of consciousness is not normal, so I want to protect her with a nasopharyngeal airway as a temporizing measure. I move on to the next part of the primary survey. I check her breathing. I want to put on her pulse oximeter, and as I do that, I automatically add oxygen because a traumatized patient always needs supplementary oxygen. She's breathing now, she's oxygenated, or at least her oxygenation is improved. We listen to the chest, there's nothing of great concern there, and so we move on to circulation. Her blood pressure is low. I'm not happy with that. We start 2 large bore IVs, and you can see that she responds to that with an increase in her blood pressure. Now, we know that head injury does not cause low blood pressure. Where we move on to disability, her AVPU level, getting a bit more precision. Not only is she not verbalizing, but she only responds to painful stimulus. So we check her pupils and we find that the left is larger than the right. At this point, we can say we have a hypotensive patient with a head injury of significance. I'm not happy about the cause of her hypotension. We look over her entire body, and there we see a large laceration which is bleeding profusely, which is clearly a part of the cause of her hypotension. We move back to the circulation, and we put a pressure on that wound. And you'll see as we do that, her blood pressure goes up. So now we have 2 large bore IVs with pressure on that wound, allowing her blood pressure to go back. So after we've done that, the pressure on the wound, I would go back to exposure because I'd had a general survey and I'd found the laceration. So obviously we respond to that. But we need to roll the patient over and we need to check under her arms. Those both were normal. We move on to secondary survey. The first focus on secondary survey is the head. I look at the scalp. We see minor bruises and some lacerations. The neck, there doesn't appear to be any wounds and there's nothing to be visualized on the face. I recheck the pupils because clearly this major concern here is head injury. I want to have a better understanding of her neurological status, and we calculate the Glasgow Coma Scale using the calculator that's in the app, and she has a Glasgow Coma Scale of 7. This is not a good situation. The Glasgow Coma is out of 15. I previously didn't intubate the patient, but now I think that this is absolutely mandated. So we go back to airway and we intubate the patient. I check for the airway, make sure there are no foreign bodies, suction her out, do the chin lift, and then remove the nasopharyngeal airway and intubate the patient. So now we have a packaged patient. She's intubated, cervical collar, 2 large bore IVs, and pressure on the bleeding wound. We don't have a CT scan, but we can X-ray her skull, which reveals no abnormalities. The X-ray of her neck shows 7 cervical vertebrae. We visualize the cervical vertebrae on the thoracic vertebrae, all of which are normal. Because she has a head injury, we want to look at evidence for a basal skull fracture. So we would examine her tympanic membranes. We would look behind her ear to see if there's a hematoma. and we would check her nose for evidence of cerebrospinal fluid leak. We check her pupils again, we shine the light in the eyes, and we see the left, even though it is enlarged, does respond slowly to light. The right responds to light normally. So we have a serious head injury, but we have a salvageable patient. We can assess the overall trauma status using the simplification of TRIS, the Kampala Trauma Score, which is used in Africa and actually in rural Quebec as well. She's 40, she gets 1 point for that. She has 2 serious injuries, so she's a multi-traumatized patient, and so she has 0 points at this dimension. Her systolic blood pressure is 70/40, which scores her 1 point of the possible 2. Her respiratory rate is 15, so she gets the full 2 points. She's only responds to pain, so she gets 1 point out of a potential 3 points on the AVPU neurological status. So we have a Kampala trauma score of 5. At this point, the patient is packaged, ready for transfer for definitive care. We're at the district hospital. We have the option of taking her to the operating room, which is her best option. If we transfer her to ICU, which is one of the options, in this case, that patient would die. If the learner had transferred TMA, okay, but we go to the operating room. At this point, we can then choose where we'd make a craniotomy incision based on the choices of incision. I don't remember which pupil was affected, but I can go to the patient log. It indicates it was the left pupil, so I'd go back, make the incision on the left side. Usually we talk about making a reverse question mark incision, so I would choose the final choice as the correct one. At the end of the case, the learner will get a debrief. The debrief here needs some work. It's a little bit boring, but it does summarize that the TMA was successfully transferred to the operating room where a craniotomy was performed. So in addition to this, I would think in the future the debrief might mention what they didn't get done, and the order of how the debrief is presented would be improved as well. So we've had an example of a case study similar to the case studies in all the CNIS courses. We're using an avatar to teach. It's interactive rather than just passive, and we have further developments as far as placeholders and activities are concerned, which will make this happen even better over the coming weeks.